Today we're going to move on to Chapter 8. And Chapter 8 is the chapter where we're going to take the bones that we learned in Chapter 7, we're going to actually put them together. Now we've been alluding to this as we've gone through and looked at the bones, but now we're going to look at the structures other than bones that make up the joints. Now the true word for joints is an articulation. So you'll hear me use that word saying, this bone articulates with this other bone. It means it forms a joint with it. Now joints are really important in terms of how the skeleton works. They give the skeleton mobility. You can imagine if we didn't have these joints, if we didn't have these movable places where bones interact, we wouldn't be able to move our skeleton, right? We'd be rigid. But whenever you have two things that come together and other structures there, you have an inherently weak point. Okay? So the articulations overall are the weak points of the body. We will classify joints based on two things, either functional classification or structural classification. Now, every joint has both a functional classification and a structural classification. So if I were to name any joint in the body, you should be able to tell me what is it functionally and then what is it structurally. So we're going to start off talking about what I mean by a functional classification. This is a classification based on the type and the amount of movement that's allowed at the joint. The three main classes that we would have of joints then are what are called the synarthroses. Okay. Wherever you see this arthrosy or arthrosis, that is basically the root for joints. Okay. So something that is synarthrotic or is a synarthrosis is immovable. Okay. So these do not have any movement. Compare that with amphiarthrosis. Amphiarthroses, amphi meaning a slight bit. Okay. So here we have these joints are slightly movable, and we will see some examples of these. These would be of the joints in the body, these number in the fewest. Then we have our freely movable joints. These are diarthroses. Okay, so we say they are diarthrotic. And the freely movable joints are those joints that we would think of as joints. The other ones are things that you might find with some surprise to actually be joints. So as we go through and look at all of these different joints in the body, all these places where two bones meet, make sure you try and think, does this move at all? Does this have a slight bit of movement, or is this considered to be freely movable? Right? That will be very important. The next part then is to classify these based on the structure. Now the structure is obviously bones coming together, so that's not what we mean. What we mean is what type of material binds the bone together and how is it organized. So we're going to say that there are three main structural classifications: okay, fibrous, cartilaginous, and synovial. Right? Now the fibrous, these are going to be connected by a small area of dense fibrous connective tissue. And we'll look at the specific examples of those next. Cartilaginous, anybody want to take a guess at what kind of material binds together a cartilaginous joint? Cartilage, yes. Okay. These cartilaginous joints will have cartilage, but they will have no space between them. You will have a direct connection between two bones by cartilage as opposed to dense regular connective tissue. And then finally we have what are called synovial joints. Synovial joints will be the most complex of the joints we will look at. These have many things, right? They will have cartilage involved. They have what's called a joint cavity or a joint space. They will also have something called a synovial membrane and synovial fluid. Okay. This category of synovial joints are what most of us think of as joints. So we'll take a look at those. But we'll start off with the fibrous and the cartilaginous. Those are a little bit more straightforward. So the fibrous structural joints, these are connected by fibrous tissue, right? Dense connective tissue. There are no joint cavities present. And these are immovable. So the term we would use, these are synarthrotic or they are synarthroses, right? Whether we're using this as a descriptive word or a noun. The three types that we will see here are what are called sutures, syndesmoses, and gomphoses. Now, these three types are going to be slightly different in their organization, and we'll use specific examples to show them off. So sutures. Sutures we've actually seen. These occur between the bones of the skull. So where, for example, the parietal bone meets the frontal bone, that area there, we had called that the coronal suture. Okay. That coronal suture is actually a joint. Here we have interlocking junctions of bones. If you remember looking at especially the real skull that I showed you in lab, the bones kind of knit in like this. If you were to look at a living skull where the soft tissue is still present, you would see that there is a dense regular connective tissue all throughout there, sealing that tight. Okay. Now these seal the bones together, but it permits growth to occur, but no movement. Right? These are completely synarthrotic. You do not want your skull bones moving relative to one another. Eventually, as we become older or completely done growing, somewhere around middle age, those bones will actually fuse. Okay. The sutures are important. You have to name a few of the sutures. Most of the sutures in the skull are named by where they're located. So we have the coronal suture, the sagittal suture, the lambdoid suture, which is named by its shape, the squamosal suture, okay, the frontonasal suture. Right, so you have seen these before. These are not new. Remember, make a note. These are immovable, so we say they are synarthrotic. The other kind of fibrous joint that we will talk about is what's called a syndesmosis. Right, that's singular, plural, syndesmoses. Here we have two bones that are held together by a short piece of fibrous connective tissue called a ligament. Ligaments connect bone to bone. The movement here, for the most part, is going to be immovable, and sometimes we have a little bit of movement that would be amphiarthrotic. Okay. Most are going to be synarthrotic. This is where we might see an example would be here. This is the tibia and the fibula. These are held together with a short section of ligament, so that is a syndesmosis. We do not want to see movement from the tibia and the fibula, right? Imagine where this joint is in the body. Here's where we're going to have the ankle sitting. Right? This forms a bracket that is going to hold on to the foot. You don't want these two bones separating or splitting or moving relative to one another. Okay, so we're going to see this as an example of a synarthrotic syndesmosis. We also have that same kind of joint between the radius and the ulna in our forearm, or in our antebrachium, right, where these two bones are held together next to one another. There's a little bit more movement involved here because we do have that ability to pronate and supinate, so there's a little tiny bit of movement involved there. Now the third kind is called a gomphosis, plural gomphoses. This is how your teeth are held in the socket. So this is a peg and socket fibrous joint that holds a tooth into its alveolar socket. If you remember when we looked at the mandible, we said that the alveolar margin was that edge of the bone where the tooth sits in. And the ligament here is called the periodontal ligament. If you've ever heard of somebody who has periodontal disease, right, it is a very advanced stage. It starts off as inflammation, then gingivitis, eventually can become periodontal disease. And often what happens is people may have healthy teeth, but those teeth become loose and will eventually fall out. Right? It is a disease that leads to the death of that periodontal ligament, and then the tooth is no longer held in its socket. Right? So those are gomphoses. These are also synarthrotic. These are not supposed to move, right? Unless you are 8 years old, your teeth should never wiggle. So those are our three categories of fibrous: sutures, syndesmoses, and gomphoses. So the second structural category are the cartilaginous joints. Here we have articulating bones that are united by cartilage. These do not have a joint cavity. So we have bone, cartilage, bone, direct connection. The two main types we will see here are called synchondroses and symphyses. Okay. Notice the synchondrosis, this has chondro right in it, so that's your hint or your way to remember that it is cartilage. And then the symphyses, we're going to see we've already looked at examples of symphyses. So the synchondroses, here we have some sort of bar or plate of hyaline cartilage that's uniting the bones. These are synarthrotic. These do not have movement. These are kind of unique joints. These are non-movable joints. So one of these is going to be the epiphyseal plate. If you remember, we talked about bone growth in long bones in children. And what we had was the epiphysis and the diaphysis. Between them, we have the epiphyseal plate, which is cartilage, and this is where growth occurs. That is considered a joint. Okay, it's specifically considered a synchondrosis. Now, we don't have movement there, okay, with the exception of the fact that there is growth that occurs. Now, in adults, that is going to fuse and become like a stenosis. So it's not going to grow anymore. It's not going to move. Okay, it no longer then has the cartilage. The other one is where we have the joint between the first rib and the sternum, specifically the manubrium of the sternum. Right? The first rib does not move. Right? It's locked in place. There is a slight bit of movement in the rest of the ribs, not a lot, but we have to be able to expand and collapse. But what you can think of is that this first rib kind of sets the size of the entirety, and it keeps, now you can't feel your first rib because our clavicle is in the way, but it keeps the opening from the chest to the head and neck open. Coming through, this is where we'd have to have major blood vessels, arteries, right? We don't have stuff coming through the openings between the ribs because there's muscle there. So all of the nerves, blood vessels that are going up to or down from the head have to come through this. So we don't want this opening collapsing at all. Okay, so we call that a synchondrosis. The other ones are the symphyses. Here we have hyaline cartilage on the edges of the bone, and then between them we have a pad. That pad is made of fibrocartilage. These are going to be amphiarthrotic joints, so there's a slight deal of movement, a slight bit of movement rather. Mostly a compression movement, a slight bit of twist. This is what we would see in the intervertebral discs. Okay. So this diagram is showing us an intervertebral disc, vertebra, vertebra, intervertebral disc. This allows for a little bit of movement and a little bit of compression. Okay. These are amphiarthrotic. They're designed for strength and flexibility. The other example is in the pelvic girdle, in the pubic symphysis, which is where the pubic bones of the os coxae touch in the front. Okay? And this allows for a slight bit of flexibility in our pelvic girdle. All right, so the last structural category then are the synovial joints. These joints are going to be structurally much more complex. These are all going to be diarthrotic, which means freely movable. We will actually spend time talking about the different movements. When I say freely movable, it doesn't mean that every joint can do every single movement. We'll see that certain joints do certain movements based upon where they are, the shape of the bones, things like that. Here we're going to have a joint that is made of two or more, usually two, articulating bones separated by a fluid-filled cavity. And we'll see supporting soft tissue structures. And these will be most of the joints that you think of as joints, right? All of the joints of the limbs, most of the joints of the body are going to be synovial joints. So what that means is we're going to see different structures, and we will talk about a few of the joints in particular, and you'll have to know the names of the soft tissue structures associated with those particular joints. Right. All synovial joints have the following parts. They have articular cartilage. Remember, articular cartilage is hyaline cartilage that will sit at the ends of the bones. Okay. It's going to allow for a nice free movement. And then we have a space between the bones that is called the joint or the synovial cavity. Now, in order for there to be a space between the bones, the two bones have to be surrounded by something to create the space. Right? That is called the articular capsule. And that articular capsule we're going to see is made of connective tissue. It's actually going to be continuous with the periosteum of the bones. And it will have an inner layer that's going to produce a fluid, and that fluid is called synovial fluid. And then what holds this all together and actually allows for the movements are going to be the reinforcing ligaments. Ligaments connect bone to bone. And we'll also see an interaction here of the muscles, so we'll see tendons that cross as well. Tendons connect muscle to bone. Now, we are not going to learn the names of the major muscles in A&P 1. So as I go through, I will have to mention muscles, right? But as far as testing goes, I will not be testing you on the names of the muscles, but I will be testing you on what do they do in terms of joints. So let's take a look at this in both a simplified diagram form and in an actual joint. Okay. Here we have two bones. These are long bones. We can tell these are long bones because we see a clear diaphysis and an epiphysis. Here we see the same. These have been cut through where the two bones come together. This blue region here, that is showing our hyaline cartilage, which is our articular cartilage. Continuous with the periosteum, we have this area here that is the fibrous part of the capsule, of the articular capsule. The inner portion is lined with membrane that's called synovial membrane, and it is membrane that can produce synovial fluid. So this space in here, this joint cavity in here, is actually full of a fluid called synovial fluid. Now, connecting these two bones together, we see ligaments, right? And those ligaments are going to help to reinforce the joint and will allow for some of the movements. We can take a look at this in a cut through of an actual joint, right? This would be an actual human joint. We do see a long bone here. We can see articular cartilage. We clearly see the space or the joint cavity. We don't see the fluid because this is cut through, so the fluid has come out. Here we see the other bone that is articulating. Here we're going to have more hyaline cartilage. Then we can see ligaments that are going to cross and cross. And this particular joint has some extra soft tissue structure here and here, which we'll talk about. Does anybody want to guess what joint this is? Take a look at the bones. Take a look at the shape. Autumn?
It's your shoulder joint.
What two bones are articulating here?
The scapula and humerus.
What part of the scapula are we seeing here?
The anterior.
No, this. Yes, the glenoid cavity or glenoid fossa of the scapula.
What is the synovial fluid made of, or doesn't it even matter?
Synovial fluid is mostly water-based, and of course has some ions in it. It has some glycoproteins to allow for lubrication. It's produced like any of the fluids that you would have in your body by epithelial tissue. It has, we're not going to go into it as much in the book if you read it. It has certain acids in it, okay, and those acids help to keep down any sort of buildup. If you've ever heard of somebody who has water on the knee is actually usually due to an injury where you get extra amounts of the fluid within the capsule. We're not going to go too much into the acids and stuff that are within it, but they're in there to keep that. You can imagine if you start getting stuff building up in here, it's going to affect movements. No. Tina.
Like when people end up with injections in their knee, like I know my dad gets synthus in his knee. Do they inject that into where the fluid should normally be?
I don't know. I'm not really sure. I mean, if they're injecting it because he doesn't have synovial fluid, maybe, but I really don't know in terms of injections. A lot of times injections in joints are steroids, and those just reduce inflammation, but I don't know. Any questions on the general structure of a synovial joint? So what you can imagine is as we look at specific joints, you should be able to identify all of these parts and specifically identify the different ligaments that we'll talk about. And the bones, of course. So this is just a nice table to review, okay? This is going to list the structural and functional characteristics of the body joints, kind of like what I was writing on the board. Right? The purple dots are going to be synovial joints, so you can see that there are many more synovial joints than there are orange dots. Those orange dots are going to be the fibrous joints. The bright blue dots, those are going to be cartilaginous joints. So when you take a look at these, this lists the name of the joint, the bones that articulate, the structural type, and the types of movements. Okay. This is for the axial region, the upper limb, okay, and the lower limb. So you should be able to go through, and obviously we're not going to go through every single one of these joints. We'll be here until next Tuesday. But this is a good way for you to review the information. Okay. Now, if you notice along this, the functional type of movements, there are most of the body joints we would think of, say, diarthrotic, but then it lists specific kinds of movements. So we will talk about those specific kinds of movements. Okay. So just refer back to that. It's a nice review chart. You should, if you know the general structure of the synovial joints, then you know them all. You know what I'm saying? Yeah. Okay. You need to know all the bones. You need to know where all the bones go. All of those that have purple dots have synovial structures, so you know that they're synovial joints. Okay. We will look at some of the specific ones that are more complex, and those you will need to know in specific. Does that answer? Yeah? Okay. All right, so there are some additional structures that we have to see at joints, specifically at the diarthrotic joints, because wherever you have movement, okay, movement can lead to friction. So we're going to see there are two main types of structures we'll see in joints, again, depending on the shape of the joint, that are going to help reduce friction. One of these are called bursa, okay, bursae, plural. These are going to be flattened fibrous sacs that are lined with synovial membrane and contain synovial fluid. Okay. So these are going to act like shock absorbers and friction resistors. We will see these wherever ligaments, muscles, skin, tendons, bones, wherever things can rub against one another, we may see one of these bursae there, or we may see something different called a tendon sheath. Now, a tendon sheath has the same structure as a bursa, right? It's a fibrous fluid sac filled with synovial fluid, but this is actually going to be wrapped around a tendon. Okay? Tendon is dense, regular connective tissue that connects muscle to bone. Okay? So this is going to wrap around the length of that. So if we look at that same shoulder joint now that we saw before, this would be the acromion. Here we have a cut through of the glenoid fossa, cut through of the humerus. We see the joint cavity, the hyaline cartilage here, the synovial membrane and capsule. Well, beneath the acromion, we have something called the subacromial bursa. The subacromial bursa is named because it is below the acromion. What this bursa does is it sits on this hard part of the humerus that will move, and it allows, as that humerus moves, it prevents this bone from rubbing up against this ligament called the coracoacromial ligament. The coracoacromial ligament goes from the coracoid process to the acromion. So it's coracoacromial ligament. Right? Most of the ligaments are named in this manner. If we didn't have that, you could imagine that the humerus, every time you move it, would rub up against this ligament and would eventually wear the ligament down. Okay? So this bursa actually helps to slide back and forth, and it absorbs the friction. Right? We also have here a tendon sheath. Okay? This is the tendon of a muscle called the biceps brachii, specifically the long head of the biceps brachii. This is this muscle here. Okay? The tendon comes from this area of the joint. We'll see it actually plays a pretty important role in how the joint functions. But every time you moved your arm, you would also have friction occurring here. So the tendon sheath actually is like a bursa, but it wraps around the tendon. So that as the muscle contracts and relaxes, that tendon is moving, it's preventing friction from causing damage. Now, you may have heard of something called bursitis or tendinitis. Bursitis and tendinitis are inflammations in the bursa or the tendon sheath. They're usually due to repetitive injury or repetitive movement, right? So you may have heard of tennis elbow is a type of tendinitis from people who do this a lot. You can also get bursitis in your shoulders, very common, right? That, especially the subacromial bursa, right, becomes inflamed. So you can imagine if your friction-reducing surface becomes inflamed, you get a very painful type symptom with movement. And the cure, the treatment for it is usually to stop moving it for a while, right? Let the inflammation go down. Questions on the bursa or the tendon sheath? Now, if we have these joints that are highly movable, anytime you have something that's highly movable, right, it's going to move. Right? And when something moves a lot, it undergoes wear and tear. Okay? And it's a weak point. So we have to have a certain degree of stability in these joints. Now, stability in a joint is going to be determined by the actual shapes of the bones that are articulating. That's also going to determine what movements are possible. So when we talk about the different movements, we'll see that the different movements are determined by the shapes of the bones. Right? The other big thing that is going to give us stability in the joints are going to be the ligaments. The ligaments, again, connect bone to bone. They will also help prevent movement of one bone relative to the other in ways other than we want the bones to move. Okay, so they'll prevent excessive or undesired motion. Okay, this will be especially important when we look at the knee. There's also some degree of stability provided by tendons, which are really the muscular part of the musculoskeletal system. Right. Muscle tendons cross joints. We always have some degree of muscle tone, right? Some of us have better muscle tone than others. But unless you are dead, you have some degree of contraction inherent in your muscles that keeps your joints and holds them together. So those three things, the shape of the bones and how they interlock, the ligaments and the tendons, are really going to allow for the joints to have stability. And they're also going to allow for the joints to have certain movements. So at the very end of this lecture, we'll talk a little bit about some of the things that can go wrong with joints. And one of the big things is, well, if those things prevent movement, if you move your joint the wrong way, you're going to hurt those things, especially the tendons and the ligaments. Two quick terms I will mention when we talk about a muscle. Right? With very few exceptions, muscles connect two bones. Okay? In the skeletal system, they connect two bones. One bone stays still, and the other bone moves relative to that bone. Right? So I always use the bicep as an example, right? Because we all know pretty much where the bicep is. Right? If you hold your arm like this, and you contract your bicep, you are moving part of your body, the other part stays still. So the part that stays still, that is the origin. So the biceps, the origin of the biceps is up here. The insertion is where they insert and move. Okay. This is going to be extremely important in A&P2 because you're going to go through all the muscles of the system and you're going to need to know all their origins and insertions. Okay. But you need to have just a vague idea of that so you can understand how movement occurs. Right? So the way this moves, the joint that's doing the moving is this joint here, which is actually a joint between the humerus and the ulna. And the movement we can describe then as being a movement in a single plane. Right? It's just moving one way. We could say it's a hinge joint. We're going to go through and say what a hinge joint is. A hinge joint is based on the shape. So that's what we're going to do is we're going to describe movement in a joint based upon how the two bones interact, how the muscle can move that joint, and then the types of movements allowed. Now the range of movements that we see, we can have movements that are considered non-axial. In this case, when we're talking about an axis, we're talking about an axis of movement. So if you can imagine taking a long nail and putting it through a joint and seeing movement along that axis, okay, then you have axial movement. Now there's some movement that's considered non-axial, so it doesn't move around an axis in any direction. It's just a slipping motion like this. Okay? And that's what we would see. We're going to look at the example in the wrist. These are just slipping movements where the two bones just slip relative to one another. We'll also see uniaxial. In uniaxial, you can put a single nail through something and it only moves in one axis. Okay? So it can only move in one axis. Biaxial is movement in two planes. Okay? So you can imagine moving a joint in one way, right, with an axis here, and then another way. So that would be a biaxial movement. A multiaxial movement is a movement in all three planes. Okay? So you can move in this plane, and this plane. Okay? So that's three movements, right? A plane through this way, a plane through this way, and then a rotation. If you can add a rotation in, then you have that third plane. So you have a multiaxial movement. It could be called triaxial, but we just call it multiaxial. So we're going to go through and we're going to look at some of the different movements. Gliding movements, these are pretty much the easiest. Gliding movements are where you have a movement of one bone slipping over another bone. Okay. This is what we would see if we were to look at the intertarsal joints or the intercarpal joints. So these are the joints between the tarsal bones or between the carpal bones. Okay. We also will see this gliding movement between the flat articular surfaces of the vertebrae. All right, so here we just have one bone surface gliding or slipping slightly over a similar surface. Angular movement, then, is when we create an angle with the joint. Okay. We can have flexion and extension. Now, if any of you guys go to a gym and work out, these terms will actually be pretty familiar to you. When you have flexion, you are decreasing the angle of a joint, so you can think about flexing your muscles. Okay. Extension is you're extending that limb out usually, and you're increasing the angle. So the angle of the joint can either be flexed and made smaller or extended and made larger. We also have something very special called dorsiflexion and plantar flexion. Right? Plantar flexion is when you're moving your foot down. Dorsiflexion is when you move your foot forward. Okay? So if you're kind of pointing your toes more, that would be plantar flexion. If you're bringing your toes back towards your body, that's dorsiflexion. Okay. So we can see this can be described in many joints. Okay. The shoulder joint can do flexion and extension. Here we have the joint of the knee, which is going to do flexion and extension. The back, in some ways, if we talk about the entirety of this here, we're not looking at a single joint, though. We can have flexion. We could also have hyperextension. Right? If you extend a joint beyond its maximal, you can have hyperextension. Now, some joints are supposed to hyperextend. Okay? So we hyperextend the neck. We're actually moving more than just a single joint. Okay? But hyperextension of the neck is allowing us to bend our neck backwards. Okay? If we do hyperextension of the back, we are bending backwards. Now, you don't want things like your elbow or your knee joint to hyperextend. Okay? That's actually quite bad for both your elbow and your knee joint because you're pushing those bones, pushing the tendons, pushing the support structures beyond their limit of where they should be bending. Now, there are some specific angular movements you need to know. We have abduction and adduction as well as circumduction. These describe movement toward or away from the midline. So abduction is to move away from the midline of the body. Right? Adduction is to move it inwards. You often see this described in movements involving the legs. Right? In exercises, if you go into any gym, there's usually this really kind of funny looking machine where you can sit in and you can push your legs outward or pull your legs inward to work out the inner and outer thigh muscles. Okay? And those are called the abductors and adductors. Right? And when we look at the femur, if you were reviewing the bones of the femur, there was a bump on the medial epicondyle that was called the adductor tubercle, and that's where that adductor movement occurs, right, through the adductor muscle. The other is called circumduction, and circumduction is a combination really of both abduction and adduction in a circle, right? So circumduction is if you can make a cone in space, is the way your book describes it, where you can actually combine the movement of abduction and adduction, so moving away and towards, right, and make a circular movement. That would be circumduction. Rotation then. Rotation is very important. Rotation is turning a bone around its own long axis. Okay. So you see this in the hip and shoulder joints. Right? You can rotate the humerus in the joint. Right? You can do this to some extent within your hip as well. You can rotate the head of the femur. You can do this between the first two vertebrae. If you remember the atlas and the axis has the dens that sticks up, the atlas sits around it, and you can rotate that atlas around the axis. That is rotation. Now there are some special movements. Okay. These special movements are usually only assigned to a certain part of the body, and a certain part of the body that moves one way or the other. Okay, so we have supination and pronation. Right? Supination and pronation is movement really of the radius and the ulna relative to one another. So when your palms are up, okay, you are in the supine position. You pretend you're holding a cup of soup in your hand. What happens here is your radius and your ulna are parallel to one another. When you pronate and you turn your hands down, you put your palms down, what you've actually done is the radius rolls over and crosses the ulna. Right? We don't see that in any other bones in the body. Okay? So this supination and pronation is going to have its own term. The other one is eversion and inversion. Okay? This is bending your foot inward and outward. So really what we're seeing is we're seeing here movement of the tarsal bones relative to the tibia and the fibula. Okay. We call that inversion and eversion. We also have protraction and retraction. Protraction is moving specifically the jaw forward. You can protract and retract some other joints as well. Protraction and retraction are very important in the movement of the jaw because it's one of the things that allows us to have speech and movement the way that we do. The other thing would be elevation and depression. Elevation and depression would be basically opening and closing of the mouth, but you can also elevate and depress your shoulders. So when you shrug your shoulders to say, I don't know, right, you are elevating your shoulders, and then you can drop them down. That is depression. So elevate and depress. Those are two special movements. And then this movement, which is called opposition. And opposition is very important. Opposition is the ability to take your thumb, the thumb where the actual pollex articulates with the metacarpal, right? So at the metacarpal phalangeal joint here, it's actually a very special joint that we'll look at. We have the ability to take our thumb, turn it inwards, and touch the tips of our fingers. That's called opposition, right? So we have what are called opposable thumbs. And opposable thumbs allow us to do a lot of very special movements, okay, that you can't do if you don't have opposable thumbs. All right, so what we're going to do now is we're going to go through, we've talked about joints in terms of what movements are allowed. So now we're going to talk about the types of joints that we'll see. Right? Again, we're talking about synovial joints. So with the exception of those few things that we classified as sutures, syndesmoses, gomphoses, synchondroses, or symphyses, we're talking about all the joints of the body. Okay, so we'll go through, we'll look at specific examples, we'll give them names based upon whether they are multiaxial, biaxial, uniaxial, non-axial. We'll also give them names based on the shapes of the bones and the shapes of the joints. Okay, and we'll also mention then the movements that are involved. So the first, we're going to use the upper limb as our main area here because we will see a lot of examples here. The first one we'll talk about are plane joints. Okay. So the plane joints, this is going to allow for only slipping or gliding movements. These will be non-axial joints. These are the kind of joints then we're going to see in the intercarpal joints, right, between the carpal bones of the wrist. Okay, that's a plane joint. We also then have hinge joints. Hinge joints, these are going to be uniaxial. Here we have a cylindrical projection of bone that's going to fit into a trough shape. Okay. So think about the hinge on a door. Right? A cylinder of bone sitting in a trough shape is going to give us a hinge, just the way we have a door hinge. Okay. The motion is going to be in a single plane. It is going to be uniaxial, and we'll see flexion and extension only. So the very clear example of this hinge joint would be the joint between the humerus and the... So the clear example of this would be the joint between the humerus and the ulna. Here we have the trochlea of the humerus. This would be the trochlear notch of the ulna, right, with the olecranon process and the coronoid process going into the olecranon on the back, or the posterior aspect, and the coronoid process going into the coronoid fossa on the front. That gives us a hinge, right? We have uniaxial movement, and we can do flexion and extension. We can also have a pivot joint. A pivot joint is where we have a rounded end of bone that's going to protrude into a sleeve or a ring of bone and or ligaments. Okay. Here we have uniaxial movement, but it's uniaxial movement in a different plane. Okay. So here we're going to see a rotation movement. This would be what we see between the axis and the atlas, the movement of the atlas around the dens. Okay. And also what's called the proximal radial-ulnar joint. So the proximal radial-ulnar joint is where the radius and the ulna articulate. Okay, so not the elbow joint that we think of where the ulna sits on the humerus, right? That's a hinge joint. But where the radius and the ulna articulate, we're going to see this really cool joint. We have this flattened part of the head of the radius. It's going to sit in a sleeve of fibrous connective tissue, and it can actually rotate in there. So that is a pivot joint. We'll see this moving, especially when we talk about pronation and supination. That radius is going to turn. The next kind are either called condyloid or ellipsoidal joints. Here we have an oval articular surface of one bone fitting into a depression or a fossa in another. These are for the most part going to be biaxial joints. So these would be the radiocarpal joints. That's between the radius and the carpal bones. And the knuckle joints, which would be where we have the metacarpophalangeal, so between the metacarpals and the phalanx. These are going to allow for movement in two planes, right? So we can imagine movement in the forward plane, okay, and then the side plane. So we have two movements here, so these are biaxial joints. This is called a condyloid joint. Then we have a very special kind of double condyloid joint, right? We call a saddle joint. So there are two condyloid joints in the single joint. And so this would be at the metacarpal joint of the thumb, okay, is where we would see the saddle joint. And this joint is where we're going to actually have the ability to do opposition. Okay. Notice the difference between the simple condyloid joint and the double condyloid or saddle joint. Right. Here we have two condyloid areas, right, and that's going to give us that additional movement. Where we might have the most amount of movement would be a ball and socket joint. Here's where we're going to have some somewhat circular or more spherical head of a bone articulating into a cup-like socket. Here we're going to see multi-axial movement because we'll have movement in both planes. We'll also have rotation. And this is what we would see at the shoulder and the hip. Okay. So in the shoulder, where the humerus, the head of the humerus, sits in the cup that is made of the glenoid cavity, and we'll see some other supporting structures, we have a ball and socket joint where we can have the different movement in the different planes as well as rotation. So we have a multi-axial joint. You can see the same thing in the hip. And we will look at those joints. We're going to look at certain joints now extensively. So we're going to go through and look at a few different joints now. We're going to start off with the knee. The knee is the largest and the most complex joint of the body. the knee joint actually allows for flexion, extension, and some rotation. And really what you have three separate joints that are surrounded by a single joint cavity. Right? So we have the femoropatellar joint, which is going to be between the femur and the patella. And then we have two tibiofemoral joints, which are between the tibia and the femur. Okay? One will be lateral, one will be medial. So we really have three different places where the bones come together, all in a single capsule. Right? This joint is going to have the most amount of supporting structures and tendons and ligaments in order for it to work. Now, if we take a look at this, we can think about the tendons and the ligaments that are involved. Very important here. Okay? Because if you think about the shape of the tibia and you should think about the shape of the femur, there's not a really tight association between those two bones, but the knee has to withstand a lot of movement because it moves every time we walk and stand and bounce. Okay. So we are going to have some important tendons involved here. Right. This would be the quadriceps muscle. The quadriceps muscle has 4 different parts. That's why it's called the quadriceps. We'll see that part of this, here we have what's called the tendon of the quadriceps muscle. Right. And then within that tendon, we have the kneecap or the patella. Remember, the patella was that very unique bone called a sesamoid bone, and it actually forms within this tendon. Once the kneecap has formed, then, we now have a tendon, and then over here we have a ligament. This is called the patellar ligament, and the patellar ligament is going to connect from the patella down to the tibia, and it will anchor right at the tibial tuberosity. The other important ligaments are called the collateral ligaments, and the collateral ligaments are on the sides. So we have the tibial collateral ligament, and that's going to come down and attach to the tibia. We also then have the fibular collateral ligament, and that is going to come down and it's going to attach to the fibula. Right? Remember, the fibula is on the lateral aspect, the tibia is on the medial aspect. We also then have, kind of behind the patella and attaching down to the tibia, right, this region here that's called the patellar retinaculum. Right? This retinaculum is going to be a way for the quadriceps muscle to connect. Right? It sits and it actually is continuous with part of the patellar tendon, right? And it will attach on the superior aspect of the tibia. Now, within the knee itself, okay, if we were to cut away the muscle, fold it open, we're going to look at how the femur sits on the tibia. Right? The femur actually sits on the tibia. There's not a tight association of bones, so we have to see certain ligaments and these other structures called meniscus, and these are going to help create that joint. Right? So we're going to look at what's called the ACL, the anterior cruciate ligament, and then we have what's called the PCL. No one usually abbreviates it, called the posterior cruciate ligament. And then we have the medial and lateral meniscus. Right? So what we've done in this diagram is we've removed all of the muscle, we've left the ligaments in place. We've also then taken the patella and cut it away and folded it back. So the patella is here. Okay? You can see the patella has on its backside articular cartilage, and it would articulate right up here on the femur. The patella articulates on the femur. Right? Here we have the condyles of the femur that articulate with the tibia. These are very rounded, much more rounded than we see the surface on the tibia. So what we have filling the space, filling the gap, are these meniscus. Right? And the meniscus is made of fibrocartilage. We have 2 meniscus. One is lateral. The lateral will always be towards the side of the fibula because the fibula is lateral. The medial would be towards the inside. These have a slightly different shape. Right? We will in lab see a video that's going to show us a human dissection, and we'll actually get to see these a bit better. So the meniscus, what it does is it helps to create an even distribution of the synovial fluid within the joint. The other 2 important ligaments are the anterior and posterior cruciate ligaments. Right? The word cruciate means to cross. So the anterior ligament starts at the anterior aspect of the tibia and crosses back to the posterior aspect of the femur. Okay? The posterior one starts at the back and crosses towards the front. So what you have is you have these ligaments forming an X right in the center of this joint, in this space that we had here that was called the intercondylar space or the intercondylar fossa. And what that does is it helps prevent movement of the femur relative to the tibia in the forward and backward direction. On this diagram, we can still see the collateral ligaments. Okay, so this would be the fibular collateral ligament, and this would be the tibial collateral ligament. We have a very nice knee model that we will see in lab today as well. So you actually get to see these on a model. Now this joint is covered in a capsule. Right? The capsule is really continuous with the periosteum. Right? That capsule is going to enclose those three joints between the tibia and the femur, the two there, and then between the femur and the patella. Okay? They'll all be enclosed by articular capsule, okay, this dense connective tissue, and then they're going to be supported by a whole bunch of ligaments and tendons. Right? At the back of the knee, this is now a posterior view. Right? The back of the knee is the popliteal region, so here we have the oblique popliteal ligament, okay, oblique meaning on an angle. You can see that there are lots of tendons, okay. This is the tendon of something called the gastrocnemius. This is the tendon of something called the semimembranosus, okay. These different tendons, if you can recognize them as tendons, that's all I'll be testing on for now, okay. If you notice, the fibula, where it attaches to the tibia, is outside of that true joint of the knee, okay. Here we actually have a connection that is just fibrous, so this is actually a fibrous joint here. You can see the fibular collateral ligament. Okay. The tibial collateral ligament is on this side here, but it's actually kind of within the articular capsule. There is a bursa here. Right? We can see this bursa because it is external to the capsule. So this is the posterior view of the knee with the capsule in situ or in position so that you can see how that joint is all enclosed. Any questions on the knee? Yes, Robbie. So the next joint we'll look at is the elbow joint. Okay. The elbow joint, the true elbow joint, is the joint between the ulna and the humerus. Okay, that is a hinge joint. It allows flexion and extension. Right? We will also see that the radius does articulate with the humerus there as well. We have a different movement at the radius, okay, how the radius articulates with the humerus and the ulna. If we were to take a look at the elbow, now this is a cut-through section, so we can actually see very clearly. This would be the trochlea. Okay, so this is that rounded portion. This would be the trochlear notch of the ulna. So here is the ulna. This would be the humerus. We can see the articular cartilage on each aspect. This would be the synovial cavity full of synovial fluid. The articular capsule, which would be continuous with the periosteum. Okay, inner layers at synovial membrane. Okay. So here we can clearly see how this would be a hinge joint. The majority of this hinge joint is stabilized by the tendons from the biceps or the triceps muscle. The tricep runs along the back of your brachium. Notice there is a bursa here. Okay. This bursa, if you know somebody who has tennis player's elbow, that's where the bursitis comes from in that. Right. Now if we look at the elbow joint with the articular capsule in place, okay, now we see the humerus, the ulna. This would be the radius. The radius is towards us, right, coming out of the page. There is the articular capsule in place. We have something called the annular ligament. That annular ligament makes a ring of ligament, and that's what the radius sits in. The head of the radius then articulates with the capitulum of the humerus. Okay. This would be the lateral epicondyle, right, towards the outer portion. This ligament here is the radial collateral ligament. Collateral ligaments are on the outside. Okay. And it's going over to the radius. It also does attach in some part to the ulna as well, but it's coming from the radius. Now we're looking at the medial aspect. Okay. So now the ulna is closer to us. Here we can see that annular ligament where the radius sits in that little ring of ligament. We still see the articular capsule. Then we have the ulnar collateral ligament, right, which is going to go from the medial epicondyle to the ulna. Okay, it does not go to the radius at all. It's on the ulnar side. Okay. And that will give the joint some of its stability. So the next big joint that we'll talk about, we've actually seen a few times in this lecture. It is the shoulder joint. It is the glenohumeral joint. It is the joint between the glenoid cavity or glenoid fossa and the humerus. It is a ball and socket joint. Here we have a really high degree of movements available. Okay, but the more movement you have, the weaker the joint is. We're going to see that what allows for this great deal of movement is we have a much smaller bone-to-bone articular surface. So we have overall a much weaker stability here. We're going to look at something that's very important and slightly different than we'll see in some of these other joints. We're going to have 4 ligaments that are going to create kind of a wrap around the glenoid cavity to attach and hold the humerus in place. Those ligaments are going to be the coracohumeral and the glenohumeral. Right? These are named by where they go and where they go to, where they start and where they go to. So coracohumeral starts at the coracoid process of the scapula and goes to the humerus. The glenohumeral starts at the glenoid cavity and goes to the humerus, and there's 3 of those. We'll also see that these 4 together are called the rotator cuff. That rotator cuff, if you think about a cuff of a sleeve, is going to help to hold this kind of loose bone-bone association of the shoulder together. So if you've heard of somebody having a rotator cuff injury, very common in pitchers in baseball who use their shoulder a lot. Okay. We'll also see that there will be some tendons that are going to serve to give this a bit more stability. So taking a look, now we have the shoulder. The muscles are, for the most part, removed. We're going to look at the ligaments predominantly. You do have to remember the parts of the scapula. Okay. So the coracoid process and the acromion. Right. Remember, the acromion comes from that ridge, right, that scapular spine that comes up. Right. The coracoid process is going to be more forward. Your clavicle is going to articulate with the acromion, just to get your bearings as to where this is. Ligament-wise, we have the coracoacromial ligament, which goes from the coracoid process to the acromion. Below that, we have the subacromial bursa, because it is below the acromion. We also have the coracohumeral ligament, which will go from the region of the coracoid process to the humerus. That is the coracoacromial ligament. We have the articular capsule, and that will be reinforced by the 3 separate glenohumeral ligaments. These are not shown individually here. So that articular capsule is going to be reinforced by those ligaments, and that's going to create that rotator cuff. And we'll see that in a moment. We also have, this is a tendon that goes to a muscle called the subscapularis muscle. And the subscapularis muscle is a muscle that is below the scapula. If you remember, this was the subscapular fossa of the scapula. That's where that muscle will go. So this tendon connects to it. Right? And you see this little jump. There's almost like a little bridge of connective tissue here. Okay. That would be called the transverse humeral ligament because it's just crossing or transversing the humerus. There are tendon sheaths, bursa. Okay. This would be the subscapular bursa because it's actually below the scapula. Now, if we were to turn this, now we're looking, if we remove the humerus, remove the upper limb from the shoulder, now we can see that rotator cuff. Okay. This is where we have a weak stability, which gives us a good range of motion. So the actual glenoid cavity is small compared to the humerus. It does have that hyaline cartilage that is going to be the articular surface. Then surrounding it, we have something called the glenoid labrum. Right? The glenoid labrum means like the glenoid lip. So this is a lip of fiber cartilage. Okay, that increases a little bit the size of this to help it sit in place. Then we have our glenohumeral ligaments that go from the glenoid to the humerus, and they kind of wrap around and are continuous with the articular capsule, and that creates what we call the rotator cuff. So the head of the humerus can actually fit in there and be held in place. What this does is this gives us a much greater allowable movement in our shoulder than we would have in, say, the hip, which bone to bone, the hip and the shoulder aren't that different. But we're much weaker. Our shoulder's much weaker, right? Much more easily subluxated, which means pulled out of socket. And we'll see that in a moment. So we will now look at the hip or the coxal joint. This is a ball and socket joint where the head of the femur will articulate with the acetabulum of the os coxae. Here we have a fairly good range of motion, but it is limited by the strong articular surfaces or the tight articular surfaces between the head of the femur and the acetabulum, and also very strong ligaments that hold this joint together. This joint gives up movement in the sake of having more strength. If we look at a cutaway of this, this would be the coxal bone. Here is the pubis. Towards the back would be the ischium. Here is the acetabulum. This would be the head of the femur. This would be the greater and lesser trochanter of the femur. We will look at the stability being due partially to how we have this rounded head of the femur sitting in this very deep pocket, or the acetabulum. We also are going to have what's called acetabular labrum, very similar to the glenoid labrum, where it's a little increase, if you will, non-bony fibrocartilage increase in the size. We'll also look at the different ligaments. So we're going to see that the ligaments, for the most part, are named by the two parts that they connect. We'll have the iliofemoral ligament, which connects the ilium to the femur, the pubofemoral ligament, which connects the pubis to the femur, and the ischiofemoral ligament, which will connect the ischium to the femur. Remember, the coxal bone are really three different parts: ilium, ischium, and pubis. And then we have this guy, which is best shown in this diagram, called the ligamentum teres. This ligamentum, this is an internal ligament. So this is within the joint, right? It is continuous with the articular capsule, and it attaches in the head of the femur. There's a little divot or a little dip, and that is where the ligamentum teres will attach. Right? So that's going to even add even more to the stability. So not only do we have stability by structures surrounding the outside of the joint, there's something on the inside holding that joint in place. So in order to see those other ligaments, we have to look at this whole. So here we have an anterior aspect and a posterior aspect. So coming from the pubis, which is coming forward to us, we have the pubofemoral ligaments. These are all going to attach right around the very edge of this crest created by the greater and lesser trochanter. Here we have the iliofemoral ligament, which comes from the inferior iliac spine, right? We have the ligament attaching, coming down, and all throughout here attaching. If we look at the posterior view, so here is the ischium, right, sticking out towards the back. Now along this region of the greater trochanter, we have the ischiofemoral ligament. Here we can see more of the iliofemoral ligament. So these ligaments are going to connect and really allow for a good deal of stability in the hip joint, which we need because every time we walk, all of our body weight gets transferred through our hips. Now we still have a good amount of movement in our hips, but not nearly as much as we have in our shoulders. Again, if you know the names of the parts of the coxal bone, naming these ligaments is very easy. Then we have what's called the temporomandibular joint, or the TMJ. This is where the mandibular condyle articulates with the temporal bone, the mandibular fossa of the temporal bone. This actually functions as two different joints, right? We're two different kinds of movements here. We can see a hinge joint occurring where the mandible will move, allowing for depression and elevation of the mandible, right? Imagining opening and closing of the mouth. But then we also have side-to-side movement, grinding of the teeth, right? Moving the jaw from side to side, and that's called lateral excursion. The temporomandibular joint for a tiny joint is actually a bit complex. Get your bearings on the skull again. Okay. This is where we would see the temporomandibular joint. It is in the right where you have the zygomatic process of the temporal bone. You have that mandibular fossa. Coming up the mandibular ramus, we have the mandibular condyle. On the outer portion, we have this lateral ligament. Okay. Then we also have this articular capsule. So if we were to close up on that and cut through a little bit, we're actually going to see, interestingly enough, we have the articular cartilage on both sides. We have articular cartilage on the mandible, articular cartilage on the temporal side. There are synovial membranes. There's a synovial membrane here and here. And what we actually have is we have two cavities here. So we have a superior and an inferior cavity. Right? And those two cavities then are going to be separated. If you have problems with your temporomandibular joint, you may hear a click when you open or close your jaw. Okay? And that click is usually due to there being problems with these two separate tiny but very important joints. This joint probably, I don't have any numbers to back this up, this joint probably gets more movement than any other joint in our body, right? Because we use it every time we speak, every time we chew. Okay? We use this a lot. It's not weight-bearing per se, but it does have to have a certain degree of strength because we do have to be able to chew through things. Right? So that is your temporomandibular joint. So now that we've seen the joints, let's just talk briefly about some of the things that can occur at the joints. Right? One of these are sprains. Sprains occur when you have the ligaments that reinforce a joint are stretched or torn. Now, if you have a ligament that is just stretched, it can repair itself. If there is a slight tear, it can repair itself, but slowly. Okay. If you have a completely torn ligament, these would require surgical repair. Torn ligaments need to be reattached to the bone. If the tear is bad enough, the ligament may need to be replaced. Ligaments can be replaced using a ligament from elsewhere in your body or part of a tendon. Tendons and ligaments, the material that makes them up is the same thing. What makes them different is where they're attached. Okay, so you can have what's called an autopathic repair, and this is where they would take a piece of ligament from one other part of your body and they put it somewhere else. This is really common repair of the knee. The other thing that can be done is called an allopathic repair. Allopathic, they take a piece of ligament or tendon from somewhere else, usually a cadaver, and they will replace your badly torn ligament with a cadaver ligament. Okay? Cadaver ligaments actually are one of the easiest kinds of transplants to do. Most of the time, if you have a sprain, sprains actually seem to hurt worse than bone breaks at times. You have tons of swelling, and it seems that they take a longer time to heal. And again, that's not, it's not that they're actually a worse injury, but bone will heal itself. Bone heals itself actually quite quickly. Right? So if you break a bone and you ignore it for a while, that bone is going to start healing. We talked about healing in bones in Chapter 6. It's much harder for ligaments to heal themselves because of the type of tissue they are. Now, cartilage can also be injured. Okay? Cartilage can be injured. It could be the articular cartilage on the bones. You can also have fibrocartilage injuries. This is what you get if you have a herniated disc or if you have a torn meniscus in the knee. That would be a fibrocartilage injury. Cartilage does not heal very well. Right? Cartilage, for the most part, if it rips, it rips. Okay? So this is a common aerobics injury. Right? It's a common injury where you do lots of jumping up and down kind of injuries. This can be repaired through what's called arthroscopic surgery. Arthro meaning joint. Right? Arthroscopic surgery, they actually make very small incisions and they go in with a tiny little camera to visualize the joint, and they make small repairs to the cartilage. Now, dislocations Dislocation is when the bones are forced out of alignment. Okay. This usually comes along with some sort of sprain and inflammation and immobilization of the joint, because in order for the two bones to be pulled separate from one another, pulled apart from one another, those tendons that are supporting it usually have to get damaged in order for that to happen, right? Because the tendons are holding the bones in place. If the bones get pulled out of place with enough force, those ligaments and tendons can be pulled and stretched. You can have a subluxation, which is a partial dislocation of the joint, really common in the shoulder, right, where the shoulder comes a little bit out of articulation. A full dislocation of the shoulder. Usually when you have a full dislocation of the shoulder, from that point on, it's easy for you to dislocate your shoulder, because the stretching that occurs in the ligaments, it kind of loosens that, and you always have a kind of loose shoulder. Now, there are some inflammatory and degenerative conditions. Okay. Bursitis is an inflammation of the bursa. This can be due to overuse or friction. It can also be due to a blow. Here you have pain and swelling. You can have excessive fluid buildup, especially if you have an injurious bursitis, where you hit the bursa and it swells and swells and swells. They can actually go in and drain some of the fluid out, drain the excess fluid out. Steroids are a common treatment here. Steroids are anti-inflammatory. Okay. Tendinitis is almost the same thing, but it's in the tendon sheath rather than the bursa. Otherwise, really the same thing. Now, arthritis. I'm sure you've heard of somebody who has arthritis. There are many different kinds of arthritis. Arthritis means inflammation of the joint. Itis meaning inflammation of, arthro meaning joint. So this is inflammation of the joint. Many different forms. You can have acute forms, which come and go, where you get some sort of infection and inflammation within a joint and it goes away. You can have chronic forms. The two that we will mention that are the most prevalent, the ones you may have heard of the most, are osteoarthritis and rheumatoid arthritis. We will not really mention gouty arthritis. I'll just mention quickly what it is. Osteoarthritis, this is a very common form of osteoarthritis. It's a wear and tear arthritis. The more you use a joint, the more it wears out. Right? Most people at some point later in life will develop osteoarthritis. It's probably just, again, wear and tear. When you use a joint enough, you get some amount of osteoarthritis. You get, within the synovial fluid, there are some enzymes. Okay, you get these metalloproteinase enzymes. And you start to get too much of them. And that starts to break the cartilage down. Right? Now, cartilage can be replaced within the joints in very small amounts. When you age and you get too much cartilage breakdown, then the bone starts to withstand that movement, and you start to get the bone ends thickening, forming things like bone spurs. Right? When a bone is under pressure, it thickens itself to try and protect itself. So you can get things called bone spurs. Okay? And that can then lead to restriction of movement. This usually starts off in joints you use a lot, like your fingertips. Okay? Even at fairly young ages, you may start to get some arthritis in your finger joints, your knuckles, knees, and hips. These are all where you might see arthritis occurring. It is irreversible. It is a slow progress, though. For the most part, the main kinds of treatments are pain relievers for pain. Keeping active actually helps with arthritis. Not moving makes arthritis worse. There's some mention of magnetic therapy. And then there are some over-the-counter things you can get, like glucosamine, chondroitin, and different glucosamine sulfates that are supposed to help with your joints. Now, rheumatoid arthritis is very different. Rheumatoid arthritis is an autoimmune disease. Autoimmune meaning it's your body's own immune system fighting your own body tissues. This usually occurs around the 40s or 50s. There is something called juvenile rheumatoid arthritis, which affects much younger people. Here you have much worse pain in the joints, deformity of the joints, lots of other things that go along with rheumatoid arthritis besides just the joints. It starts off with synovitis, which is an inflammation within the synovial membrane. Okay. The chemicals that then are released, your body starts fighting the synovitis off as if it was a foreign invader. Your body then, when you fight off a foreign invader, you get inflammation. That's normal. But now when your body's fighting off your own joint, you get inflammation in the joint. Very bad inflammation in the joint. And after a while, the synovial membrane will start to thicken up, and that will start to erode away the cartilage, and you'll get scar tissue forming. Okay. So you can get what's called ankylosis. These are these very bad swellings within the joints. You see them most commonly in the hands of people who have rheumatoid arthritis, where the fingers bend outwards, okay, and they have these thickening of the knuckles, right? And their hands often cannot be used then. But you can have that in many other joints as well, okay? Rheumatoid arthritis, it's got what's called insidious onset, so no one really knows what kicks it into place. It usually can be treated using immunosuppressive therapy. The problem with immunosuppressive therapy is it suppresses your immune system. So you're going to be more prone to getting other infections. You've probably seen the commercials for Enbrel on TV. Enbrel is a biological response modifier or biologic medicine. But it can have lots of effects. But if you're suffering really badly with rheumatoid arthritis, it's one of these things that is kind of a godsend for people who have rheumatoid arthritis. The last kind I'll just quickly mention is gouty arthritis. Gout is a kind of odd disorder in which uric acid crystals, which should be taken out through the excretory system, they stay in the body and they get deposited in the soft tissues and they lead to an inflammation. Okay, and gouty arthritis, if you have gout, one of the classic symptoms when you're having a gout attack is that you get pain in the base of your big toe. Okay, for some reason, when you have gout, and this occurs over and over again, you get this deposition of these uric acid crystals, and eventually what happens is the bone ends can fuse, and then you lose movement in your big toe. Now, you might not think about your big toe being that important, but when you walk, your big toe actually functions as a push-off point. So if you have pain in that, or you have lack of movement there, just walking becomes very painful. Okay? There are a few different treatments for gouty arthritis, and there's a lot of lifestyle change that can be made. Now, in terms of development, we see the skeleton in Chapter 6. We looked at the intramembranous ossification and endochondral ossification occurring. By very early on, the joints actually start to resemble adult joints. Okay. We will still see changes as the bones fill out and form in, but the joints are kind of in place. Most children, with the exception of things like rheumatoid arthritis that can affect juveniles, have very little joint problems. Right? Children have very flexible joints as opposed to adults. The older you get, the less flexibility you have. When you have a lot of flexibility, you have less chance of injuring a joint. Okay. I was upstate this weekend with my daughter who's 2 and my nephew who's 3 and my friend's daughter who's 4, and these kids were going on a slip and slide, and they were like running full force and like jumping on the slip and slide, and like legs were going this way and arms were going this way and flipping head over. If I like tried that, I would come in a body cast, right? My joints just cannot bend that way. And one of the reasons for that is as you age, our joints tighten up, partially because they need to support more weight. Right? My daughter weighs a whopping 23 pounds. So her joints don't really have to support a lot of body weight. Okay? As we age, we get bigger. Our joints have to withstand more weight. Our bones get heavier. We move more. Also, as time goes on, our ligaments and tendons starting to get shorter. They start to get weaker. So our joints are one of the first things to go. Right? If you think about any place where you have movement, right, that's the first thing that's going to go. Right? If you have a house and a door that opens and closes, your door usually falls off its hinges before the whole house falls down.